data related to potassium in kidney disease patient and some epidemiological data and some strategy to finish up with. This is a new chelator of potassium. And as you know, we have to, the intestine is the organ when we have the input of potassium, and the kidney is the output of potassium. But the majority of potassium in the body is concentrated in intracellular fluid. Every day you average have 100 milliequivalent of potassium in dietary, and you eliminate them in the stool, but knowing that you have an exchange constantly between extracellular water and intracellular fluid by 65 milliequivalent. You can see here the concentration of the organ is different, the muscle having the majority of potassium, but you can have also in red blood cells too. Once you have a CKD patient, then you need to eliminate the potassium. This is a very old study. They use serum creatinine, and you see the serum creatinine increase, but potassium excretion too increase. This is mean that remaining nephron is working to try to eliminate it, the potassium load in our patient. In animal model, this is has been tested in dog, and if you have nephrectomy, then right away, then you have a decrease of elimination of potassium, and then you have an increase in the blood, but even after 7 days, the remnant kidney that then can restore the normal elimination of potassium. So we have a compensatory mechanism in our body to restore this elimination of potassium until certain degree of CKD. Then when your kidney has no way to eliminate too much potassium, then you have the elimination by the intestine, and you can see here dialysis patient, CRF patient, and normal function. And usually this elimination by intestine and normal renal function is too low. But if you have it in dialysis patient, and you can see this is too high. However, I should say this is mechanism appear only when you have less than 15 milliliter by minute. So we still have some compensation mechanism by the body to eliminate the potassium low. The big problem in our CKD patient, as you say, you know, this, the potassium is intracellular space. So when you have a potassium overload, everything is concentration you can eliminate by the kidney, by the intestine, but the major compensation to protect you against hyperkalemia is the movement from extracellular to intracellular space, and this is under dependence in potassium, sodium ATPase. And what happened, this uremic toxin blocks this enzyme, this transporter, so there are no transport anymore from extracellular to intracellular fluid by potassium. So our patient, not because not eliminating potassium in kidney, not eliminating potassium in the intestine, but they have, and when you have load of potassium, they have difficulty to move the potassium intracellular, they shift inside. So it's very prone to have hyperkalemia. So you may ask when we start to have this hyperkalemia and what is the prevalence of hyperkalemia. This is a word coming from a French cohort called NephroTest. And Olivier Morin done this work and looking about different, let's say, metabolic abnormality in this patient. We will concentrate today to hyperkalemia, and you can see there are 17% prevalence of the complication, and you can see prevalence even patient treated with hyperkalemia. If you divide it by EGFR, and here that's not estimated by, I'm sorry, this measured EGFR, And then you can see the hyperkalemia appear when you have less than 40, and clearly appear when you have less than 30, and the majority when you are in stage 5. So before, there are some patients having hyperkalemia, but the hyperkalemia due to decrease of renal function appears when you CKD become stage 4 and 5. But you have not only this level of CKD, but you can have also diabetes, which is specific. The diabetes patient, some of them have a destruction of macula densa, and then this have prone to hyperkalemia. To protect the progression against progression of renal disease, we use RAS inhibitor, and RAS inhibitor also is prone to increase potassium in this patient. We use also starting to use anti-aldosterone 1 now. So we have many factors leading to increase potassium in our patient. And remember, the bottom line, there are no shift between extracellular to intracellular fluid. So what happens if you have a hyperkalemia? This is a study from general population showing that if you are in normal level of potassium, you have no death, no cardiac arrest. But if you increase the potassium, also even if you decrease the potassium, but let's focus in here, you can see a high increase of death and cardiac arrest. And this is other study, similar U-curve, normal level, no mortality, higher level of potassium, higher mortality. Interesting enough that we did this study with people from La Riboisière, which related to heart failure patients. And we have this U-curve, similar with the normal potassium is no mortality, higher potassium, higher mortality. And we have the chance to look about the different level of renal function in this patient. And you can see if you have a normal renal function, let's say no chronic renal failure, the threshold of increase start at 4. But if you are in really less than stage 4, the threshold is 4 and 5. It seems like some tolerance instilled in our patient to tolerate the hyperkalemia. What we can do to modify this hyperkalemia, you have this dietary restriction, but you know this dietary restriction is not realistic in our patient. They have too many dietary restrictions for different things, so at the end they will not follow. When you have a renal function before to have in this stage, you can use diuretic, especially loop diuretic, and which potentialize also the effect of RAS inhibitor to decrease the level of blood pressure. Sometimes you may need to stop the RAS inhibitor therapy in some patients, especially diabetic patients when they have hyperkalemic one. And then when you have hyperkalemia in cardiac manifestation, you need to go to urgent manner and up to hemodialysis. So we are looking to have a drug to help us to keep RAS inhibitor in this patient, to keep as many diabetic patients to treat it by RAS inhibitor, even when the CKD progress. And then we have, in the historical way, this is polystyrene sulfonate sodium, which is this polymeric exchange resin, and we have to use what's called K-oxalate. And this is a potential adverse effect. This is a lot of gastrointestinal complication. I should say that it is historical drug, never evaluated by phase 1, phase 2, phase 3 trials. And that this is many drugs we use coming from 50 and 60. There are no evaluation at that time for this drug. Its work, maybe not so as we expected, but the problem with gastrointestinal and some of case has been reported that it could be a major problem. So recently there are 2 new drugs to have the similar action of sodium polystyrene sulfonate to keep this potassium down to have what we call enhanced enteral potassium elimination. Batriromer, which is this non-adsorbable polymer ion exchange enzyme, have to work in potassium in the colon. There are too many studies here. I put you the name of the study showing that efficacy of this drug, but they still have some adverse effect, gastrointestinal one, and even it is sometimes it's very so efficacious to keep the patient to hypokalemia side. There are some data that have worsening renal function and have a lot of drug interaction. And I come back to this point later on. There are no safety data beyond 1 year yet. The second one is sodium zirconium, which is also non-absorbed cation exchanger. Here you exchange potassium for H+ in the intestine. And this is have also different study published. And adverse effect is also limited, less than we have in batriromer, but we have also no safety beyond 1 year. I show you a few examples of the efficacy of these drugs. This is batriromer study published in 2015 by Matthew Weir, showing that if you have it immediately, 1 day maybe, you have a decrease of potassium level, and then you have to continue to decrease until you stabilize on between 3 to 4 week treatment. He wants to check if there are difference between aging population, not aging population. As you know, the aging population are more prone to have hyperkalemia for different reasons, and this is the efficacy of the drug was similar in this post hoc analysis of the same study. The other one, sodium zirconium, is have a similar way. It depended the dosage, if you have 5 gram or 10 gram. Anyhow, immediate decrease for 1 day, quick efficacy and long efficacy if you have long follow-up for 15 to 2 weeks to few months. The major problem of this drug is not only the efficacy and side effect. They have no evaluation of what happened of mortality. If we wanna to use a real innovation of this drug, we need to have outcome study. Because I show you an epidemiological study that we need to look at if hyperkalemia is associated with outcome. Treatment should lead to decrease the outcome, and then we believe that it is a very good drug for our patient. So I show you one example how it's possible. This is also a nephrotest group work. We look about the correlation between kalemia and mortality and cardiovascular death. And we find no correlation in our patient in nephrotest. What was the difference between this study and the different study I show you that hyperkalemia is associated with mortality? And the difference was that we tightly regulate the level of potassium in this patient by different manner. So the majority of the patients in this study were in the normal level, let's say between 3.5 to 4.5. So yes, this is indirect evidence that if you intervene to treat the patient to correct the kalemia at normal level, you may end up with flat correlation with mortality. But this is need to be confirmed by randomized controlled trial by these 2 new drugs to show us that it's really, this drug is not only efficacious to decrease potassium, but also efficacious to decrease mortality. Let me remember you what I speak today. The adaptation of increase of potassium is could be renal, intestinal, but also this is maybe we need in the future think how to modify the activity of NA potassium ATPase in this patient, which is related to uremic toxicity, which is one of my favorite topics. Certainly is secretion of potassium, it's increased. I didn't show you that there is no correlation with aldosterone except if you have load of salt. Gastrointestinal play a role, but in stage 5. Intracellular potassium is really the key problem in this patient, and we need to really look what is uremic toxin responsible for that. Increase in potassium in our patient not related to CKD only, but also to diabetes, and use a RAS inhibitor. This hyperkalemia is associated also with hypokalemia, increase the level of outcome of mortality and cardiovascular mortality and cardiovascular complication. It seems like the threshold of potassium associated with poor outcome is slightly different between CKD patient and general population. In general population, it's 4.5 or 4, and our patient between 4.5 and 5. We need this is tight window. We need to keep this potassium in to a safe window to avoid this increase. And I'll show you one example. This epidemiological data, but it's showing if you treat this potassium correctly, you end up with less mortality and less cardiovascular complication. The new drug to enhance enteral potassium elimination is certainly added value to control potassium level. I would like to look for outcome trial in this drug to see whether or not it's really the control of potassium in our patient protect against increased cardiovascular and overall mortality. Thank you very much for your attention.
Okay, thank you, Ziad. Any questions from the floor? Yes, microphone 2 at the front, please.
2 comments. If the potassium, as you rightly said, remains above 6.5 in the CKD patients for a while, there is a danger of sudden cardiac arrest. Yes, that is well recognized. Second, there is a group of patients, pediatric or adult, who have undergone a cardiotomy or have suffered acute myocardial infarction, injured heart. They are more susceptible for even a subtle level of hyperkalemia. What will you comment?
You have always a patient with a increase of susceptible to increase potassium, and in our experience that it's hyperkalemia is dangerous, but hypokalemia is more dangerous than hyperkalemia in our patient. And hemodialysis patient, if you shift quickly from hyperkalemia situation to hypokalemia, you end up with arterial fibrillation. So in many of our patients.
Maybe I'd just like to ask you if these levels of potassium you're talking about are really realistic in your CKD population, because I don't think I'd be able to treat anyone with a ACE inhibitor and ARB unless I allow the potassium, in our unit we'd allow it to go up to 6. Are we wrong?
Well, it's not wrong. I should, in any therapeutic action, you have a trait to pay something for any side effect. If you believe that RAS inhibitor is a better drug, the best drug to protect against progression, you should keep it, but you should try to limit side effect in this patient. So to my opinion, we should not stop the RAS inhibitor in this patient and try our best, this is what we did actually for nephrotest, you see, to decrease the level of kalemia around 5 to protect them. So this is it's not so easy to do. In some patients, you end up with stop of RAS inhibitor, but I think it's I saw many patients coming from cardiology department when the first reflection that stop it. No, you try first. If you don't win to decrease the kalemia, you can have. Remember this patients have prone to support hyperkalemia for different reasons. Probably they have intracellular organisms to protect against the change. They are more prone to have a cardiac arrhythmia when they hypokalemic one. So it's, I agree, it's some of the patients we end up with stop the plan, but we need to try until then.
Okay, well, thank you very much, Ziad, for a good, nice talk, and thank you to the audience for coming and to all our speakers for this interesting symposium.